Hi, my name is Nicole Sykowski, and for my medical terminology report, I am doing 3 different body systems. My first one is for the whole body as a being, and the disorder is called hyperhemetrophy, and that is when one side of your body, whether it be limbs or literally your whole body, is one half is asymmetrically larger than the other half. And this occurs in 1 out of every 860,000 children each year. And though there is not a specific cause of why this is occurring, there are many theories. These theories include abnormalities in the vascular and lymphatic flow, lesions of the nervous system, endocrine malfunctions, chromosomal abnormalities, and defects in the embryonic growth. And these features that are affected can include the pupil, the ears, half of the tongue, the thorax, the abdomen, the other extremities, upper and lower, and this can even go to the bones, which is where the aging is accelerated on one side of the body than the other. And it can also impair the internal paired organs, and that means that the kidneys left side could be larger than the right side. And there are 2 different types, and the 2 types are total and limited hyperhemetrophy. The total hyperhemetrophy is when all the organs and systems are affected by this, and that includes the organs as well, and that can also include the thickness of the skin on one side of the body. The limited hyperhemetrophy is typically only the muscular, the vascular system, skeletal, and neurological involvement. And the way it is diagnosed is best done when it's the most severe form, which is when one person's body can, on the right side, be a few inches different than the left side. The right and left side can be a few inches different. However, more of the milder cases are the ones that are difficult to diagnose. And when it is diagnosed, it is done with the help of a very careful and detailed physician who is looking and knows what this disorder is. And the main thing that needs to be done when they are diagnosed with hyperhemetrophy, it's best when it's done at an earliest age. However, it can not often be diagnosed at birth. It typically happens further on when they start developing, so a few months old. And this is really important to catch at a young age because children with hyperhemetrophy are more susceptible to getting tumors. And these are malignant tumors that can potentially be formed. And these tumors, there are 3 main types that they are predisposed to. The first one being the Wilms tumor, which is the most common that they're predisposed to. The adrenal carcinoma tumor, and then the hepatoblastoma tumor is the next one that they're most predisposed to. And there are no treatments for this disorder. They typically live with it throughout their whole lives. The severe cases do need some kind of surgery or orthopedic help just to help with their mobility because they have issues walking. But more milder cases can be put into like gymnastics, things where they're stretching all the time, yoga, where they can kind of get in tune with their bodies. And every once in a while, they'll kind of need help from an orthopedic standpoint, just so that they do not form a type of scoliosis, just from how their limbs are different lengths. And with their screening for their tumors, it is done by abdominal screening, so ultrasounds. And for children it is done every 3 months till about the age of 7. And then at that time they start going only every 6 months till about the age 13. And at that time they are considered to be matured in their growth. And at that time the doctors feel that they are able to go on without having the increased likelihood of forming these tumors. And I have found that it was really interesting learning about this just because there were some genetic things that I really didn't understand before, and I really didn't know the different type of tumors that children with hyperhematrophy can get. And I chose this disorder because I do have hyperhematrophy. I have a very, very mild case. I was diagnosed when I was a few months old and had to get the ultrasounds on my abdomen every few months. And it was just a little interesting growing up, going to the hospital all the time, getting that jelly rubbed on my stomach. It can be really traumatic for children. However, with family that is really there for the support, it isn't that hard to deal with. Then again, I also did have a very, very mild case. But yeah, no tumors. My second situation I had was for an immune system, and that is called, the acronym is called FAPA, and it is, the long version of the words are syndrome of periodic fever, aphthous, stomatitis, pharyngitis, and adenitis. And that is pretty much defined to be frequent fevers, and they can also have signs of canker sores in their mouths. And the fevers can range from 99 degrees Fahrenheit to 105 degrees Fahrenheit, which is the time where you can be going into seizures, cerebral seizures, because of how warm your body is becoming. And there are two main ways that it's diagnosed. The first one is the clockwork periodic fevers and episodes that are considered. And they occur about every 4 weeks and have a pretty good interval of like 5 to 6 days of it happening. And this can be accompanied by respiratory tract issues or it's not accompanied by respiratory or anything. It's strictly just a fever. The child typically feels fine, just a little cold. And then the second cardinal factor for diagnosing this is the child is complaining of having a low appetite, having energy that is lower than normal, may lose a few pounds during this episode, and their growth and development can kind of slow down during those little episodes. However, once those episodes are done, the child bounces back very quickly, and it is like nothing ever happened. With that, other diseases that can kind of mimic FAFSA is that can be excluded very carefully when there is attention paid to these children are the patient's ethnicity when the physician is looking there, the family's history, the associated symptomology, and results from simple laboratory tests, which include a complete blood counts. And the main complaints that the physicians get from their patient and the parents are that the periodic fevers are more prevalent over the canker sores. So the children can have that fever but really don't show that canker sore. However, they can at some times, but once that fever breaks, the canker sores go away and it's like nothing ever happened. Tonsils are modestly enlarged and can be asymmetrical, and they do not have any kind of issue with like swelling, but they are just enlarged. And there can be some kind of sensitivity to their abdomen. However, it's nothing serious. It's not like an appendix is bursting or anything. It's just tender. And the physicians and everybody do not really know what causes this. However, because it kind of follows that walks like a duck, talks like a duck kind of thing, where it walks like an infectious disease, but it talks like a immune dysregulation. So there are those two possibilities, but again, it's not like it's just one specific thing. It kind of plays with both of those. For the immunological dysregulation, it follows that by having a persistence of identical episodes of FAFSA over years. So this isn't just a few months, this is over a few years. And this is without progression, not getting worse, not getting better. But it can be seen as an infectious disease in that sense, in the sense that it responds to a fever. The child's fever is responsive to Tylenol and Motrin and stuff like that. So like fever reducers do help lower the fever so the child does not go into a cerebral seizure. So that's a kind of area where it does look more like an infectious disease. However, there is no like definitive, yes, it's this, no, it's that kind of thing. There is like a cure in a sense, and that would be a tonsillectomy. And some FAFSA patients do show no more symptoms, no more episodes after having their tonsils removed. However, there are still some patients that do. And typically this syndrome does relieve itself after a few years. So around the child turns about 10 or so, they do typically kind of grow out of it and their episodes become shorter and less symptomatic. Not symptomatic, but just less severe. And the children can still go to school during those episodes. They can participate in gym class. They can do anything they want. They just really need to kind of be sure on, oh, I'm starting to feel cold again, so I need to go to the nurse and I need to take my fever medication. And they are not contagious at all. The interesting thing I found about the syndrome was that it wasn't, like, there wasn't a specific cause. And I found that really interesting because so many children are having this that their parents just think that they're having this awful, like, infection. And there's nothing that they can do. And I chose this actually because my sister, who we adopted from China, has this syndrome. And now that she's turning about 12 now, she has slowly started growing out of this fever episode. And, I mean, she runs around and plays with her friends when she has her fevers. However, she did when we were first learning about her seizures and before we got her diagnosis, she did have a cerebral seizure. And though it lasted only a few minutes, we did have to go to the hospital and there was a ton of testing done. And because there is no genetic influence on that, there was nothing to indicate that she had this disorder until a few years ago when we were at Children's Memorial Hospital. And they were able to, out of the blue, diagnose it because they had just learned about it from reading the article that I actually read. So it was kind of interesting learning and reading what the doctors had read when they were able to diagnose my little sister's syndrome. And then my third was a respiratory system. And it is a disorder called VCD, also known as vocal cord dysfunction. And this frequently mimics or confounds asthma. And it is characterized by a paradoxical adduction of the vocal cords in inspiration. So when the vocal cords are working, they are typically working normal when you're breathing. However, when someone is having a VCD attack, vocal cord dysfunction attack, their vocal cords are sticking together when they are breathing in instead of opening and expanding so they can go have oxygen. And when it sticks together at the very top, they have a little like diamond shape opening that stays open, so it kind of like sticks and then opens up at the top right here. where they can still get some air in, but it doesn't fully regulate properly. And that little diamond is called a quick, I believe it's called. And that is it's kind of like an airway obstruction in a sense. And it causes wheezing, chest tightness in the chest, and shortness of breath and coughing. And it can also impact the vocal cords to the sense that it will make a high-pitched voice for the individual when they're having an episode. And this presents clinically as very dramatic and is misdiagnosed as either asthma, which leads to inappropriate dosing treatment of high doses of corticosteroids, and it can also be misdiagnosed as anaphylaxis, and that can lead to intubation or even tracheostomies, and that are not even needed at all because the individual can still breathe. The airway does not close enough for a person with VCD to fully not get oxygen. It becomes just so little that they just struggle for it. And it is believed to be that about 40% of patients who are diagnosed with asthma actually have VCD, and possibly asthma along with it. And this can be very confusing and harmful to the individual because they're taking the corticosteroids that they don't need at all in their body. Their body is doing completely fine. It's just a dysfunction of their vocal cords. And the common complaints that patients with VCD complain of are the throat tightness, the voice change, and difficulty to inhale. And this occurs mainly during the day for VCD sufferers. And this can be brought on very abruptly. There doesn't have to be a specific trigger, and then it can resolve abruptly as well. However, there are some triggers that can be occurring for some students, some patients, and that can include exerting themselves physically in exercise, or anything from like smoke in the air that can also trigger their symptoms. And these symptoms can sometimes be temporarily relieved by making the patient's attention be diverted to something else, so they're not focusing on, oh my gosh, I'm having trouble breathing, oh my gosh, I sound like Minnie Mouse. And it can be very scary for some people who do not know what is going on, and medical professionals in hospitals for urgent care do not really know what it is, so their first thing will be to intubate them, or it'll be to give them a tracheostomy. They do not need that. They just need to kind of like breathe a little bit and calm down and get that episode under control. And women are the majority of individuals who are diagnosed with VCD, and these patients can typically be shown signs of perfectionism, depression, and anxiety symptoms as well. The diagnosis of this dysfunction is by the use of a flexible fiber rhinolaryngoscopy. Sorry, I messed that up. Well, the patient is experiencing either a spontaneous or an induced symptom episode. And this can be done, like I said, by exercise. So the physician can have the individual go up and down the flight of stairs, run up and down the hallway, kind of get them in their symptom of their dysfunction. And once that happens, they'll put it down there from the nose down through their throat, and they will look at how the vocal cords are reacting, and they will be looking to have the vocal cords, and if they are not looking to have them, but they already have them, of course, they will be looking to see if the vocal cords are they adduct anteriorly from the vocal process, and the posterior gloidal clink remains open, which is that little diamond shape. And the presence of that glottic clink is the telltale sign of having VCD. And a patient can be asked to repeatedly make a low pitched E sound, then a high pitched E, and then a ha 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 kind of sound with their mouth closed. So it's like kind of that kind of sounds. And if the patient can show some kind of benefiting from making those sounds while they are having that scope done, those individuals can potentially benefit from having speech therapy to kind of help them with breathing exercises when they're having their episodes, and kind of lower the laryngeal muscle tone, just so that you kind of have more control over your vocal cords. And this is taught in 1 to 2 hour sessions, and those who are willing to learn how to control their episodes can benefit most from these speech therapy lessons. I found this article very interesting because it showed that there were the different types. I didn't realize that vocal cord dysfunction could be by itself or along with asthma, and that there are really that many people who have VCD that really don't know about it. And then I chose this because I was diagnosed with VCD, vocal cord dysfunction, in 2014 when there was a huge fire in Canada, and it brought smoke all the way down to the state of Illinois, where I was in band practice, and I had a very low oxygen intake, and my nurse was very good at her job, and she's like, well, you need to go to the hospital right now. You don't need to be intubated, but you're going to the hospital, you're going to get some oxygen, and you need to go to Children's Hospital. So they luckily were able to go there. We were luckily able to go there, and was diagnosed finally that it was VCD. And from then on, I had speech therapy, which really helped me. I end up sounding like Minnie Mouse when I'm having an attack, which can be brought on by smoke in the air, or if I exercise too much. So it was just really interesting learning about my vocal cord dysfunction and about the other two issues that I talked about today. And I hope that you guys learned something too.